For Medskl.com, I'm Dr. Sanjay Sharma, and welcome to If I Knew Then, a show that's based on a very simple premise that when everything is said and done, life comes down to a few key moments and decisions. On today's show, we're thrilled to have Dr. Guyatt, who really needs no formal introduction. He's one of the founders of evidence-based medicine. He's a professor at McMaster University. He's a multi-award-winning professor and researcher. He's won CIHR's Researcher of the Year and recently was inducted into the Canadian Medical Hall of Fame. So, Dr. Guyatt, it's an absolute pleasure to have you on the show, and welcome.
Thanks very much.
So typically we start the show off by just going back to how it all started out, and maybe just take me through a little bit about where you grew up and maybe some of the influences that you think, made you what you are today.
So I spent the first decade of my life in the eastern part of Hamilton, in near what was then Civic Stadium and became Ivor Wynne Stadium. And I remember that in those days, when I was a kid, people went to the stadium and they need a place to park. And since we moved when I was about 10, it must have been that I was an 8 and 9-year-old. I collected 50 cents for everybody who would park in our driveway, which was about a block or two from the stadium. So that was my.
So you were an entrepreneur at that time.
I was going to say my entrepreneurial instincts died out very quickly, and that's why I ended up in academic medicine, where everything's done for you and you just sort of have to go and do your job. But so that's perhaps a sad evolution, but I started with that entrepreneurial instinct. We then moved to a different part of town, a much more upscale part of town. And in terms of influences, my mother was a Jewish concentration camp victim.
Wow.
And she was at Auschwitz and Belsen, and I think her perspective experience influenced me. I think in my social/political activities. So I was a co-founder of a group called the Medical Reform Group, which was advocating, went on for 30 years, has been kind of succeeded by the Canadian Doctors for Medicare, basically advocating for a universal, high-quality, single-payer care for all Canadians. My dad was an extremely disciplined guy, and I think I got my self-discipline for him, and he was also passionate about the English language and the precise use of the English language. And I think I picked some of that up as well, and that has really helped me. I think a big part of the success of our group is that we write very well. There's a bit of an irony. You mentioned that I got CHR Researcher for the Year. The citation for the CHR Researcher of the Year is all my work in evidence-based medicine, which is basically education. So I got Researcher of the Year for my education activities. A big part of why that has caught on to the extent it does is the work, I think, is well written. And my father's passion for the English language, I think, influenced that.
That's very interesting. Now, the impetus to go into a career in medicine, where along the, was that in high school?
Well, no. So high school, I never did a biology course. Never did a biology course in my life. Never did any sciences. That was too interesting for me. And then after about second year university, I somehow got the need to want to do something really practical. My undergraduate majors were psychology and English, and somehow in either of those, it didn't meet the need that I felt at the time to do something where I could see right away that I was helping somebody. So with no science background, so in my third year of university, I started doing some high school courses to make up for the lack of science. It looked like it might be a long haul, but fortunately, there was one university in the country that didn't demand any science background. And that was McMaster University, the one university for which I was eligible. And when I got in, my classmates were backgrounds in archaeology and sociology and this kind of thing. It was at that stage, Mac was very innovative, taking people, they wanted people from all sorts of different backgrounds. So I got into the one medical school that I was eligible for in the whole country, which happened to be in my hometown. McMaster, born in Hamilton, and here was the one university medical school that for which I was eligible.
That's interesting. Now, I'm going to hop on just, the way you present it is, back, a number of years ago, it was a social experiment. And I'm interested now, a number of years and decades later, how do you feel about that social experiment? Was it successful? What elements of the program, I think, is there a few elements that could be replicated across the world? Because I know certainly a number of schools have adopted, various parts of McMaster's curriculum.
Oh, the problem-based self-directed learning is now standard components of, I don't know, I got the impression it was most medical schools. And 20 years after we did it, Harvard started a similar program, calling it the new Harvard program. Failure, we thought, to adequately acknowledge McMaster. But now I had the impression that most medical schools in the world had some problem-based, self-directed, small group process as part of the way they conducted things.
And is a success the change in the curriculum, or is a success a change in how we've brought in medical students? Because as you mentioned, your some of the inaugural classes, were archaeologists and people from quite varied backgrounds.
There are many ways in which McMaster has abandoned the progressive policies that started. And as far as I can tell now at Mac, everybody needs a science background, and it's your marks to get you in, which wasn't the case. So so that's definitely a failed part. If backsliding toward traditional approaches for deciding who gets into medical school, if that backsliding constitutes a failure, that was a failed part of it. Of course, unfortunate from my point of view, since looking back, I wouldn't have been able to get in, but there you go.
Now I'm interested. So, you were doing essentially like an English degree with some psychology. Did you see yourself as a writer? Who became a physician, or how do you position that?
In my final year as an undergraduate, I went out to the Banff School of Fine Arts, and I spent the summer in the Banff School of Fine Arts and their writing program, starting a novel, which I got a little bit of the way through, and then started medical school. And that was the end of my fiction writing career. But I think all that background, as well as I've told you about my dad and his influence, the English I did in university, and thinking that I was interested in writing, that also I think has contributed to the success we've had in the group as medical writers.
That's interesting. And I'm always, we've had a few other guests on the show who came from, backgrounds where there are concert pianists and, performing arts. And, I'm always struck with this sort of tension between science and arts, and ultimately, what makes the best physician. So I'm just interested in your thoughts, kind of coming from fine arts, coming from writing. How has that influenced you as a physician? And can we say that is, the fine arts is important in terms of, humanity and empathy for, for our patients?
Well, I guess certainly humanity and empathy is crucial, and caring is crucial. I don't know. Being an evidence-based guy, when I get this kind of question, I think, oh, I wonder if anybody's studied associations between your background and your empathy. I don't know. I don't know. I'd like, of course, to think of myself as an empathetic physician. Um, if I were, if you had just asked me off the top, where does that come from? I'm not sure it would be my background in English. I would immediately say my mother's background as a concentration camp victim was where that came from for me. So I don't know. So you're asking me, it strikes me uh, uh, again, being I, doing the evidence-based medicine thing, I found certainly for me, it changes my way of looking at the world. And when I'm asked something of which in a past life before I was introduced to EBM as a medical student, or sorry, as a resident through Dave Sackett, I was I might have tried to say, well, I think that, yeah, this education and the truth is I have no idea. And whether there's any evidence about the matter, it'd be interesting to know, but I don't know.
Now you brought up, Dr. Sackett. So walk me through what it was like. And I guess that was during your residency you were exposed to him initially. And so take me through what it was like having him as an influence in your life, potentially as a mentor, what that meant, what he was like.
Well, Dave was a wonderful, spectacular, unique, charismatic guy. When I entered the master's program in Clinepi, he was off on sabbatical for a year. He was my natural mentor, and Jack Hirsch was my first mentor while Dave was away. Dave came back. He basically took over the lead in my mentorship. So he was all the things that I have just said. He was also a humanitarian. He was an inspiration. He also had extremely high standards of rigor as a scientist. He was also an iconoclast who liked to perhaps, who liked to upset people, or at least who liked to challenge people in a way that they found uncomfortable. He was the guy who inspired the department that was clinical epidemiology, now has become health research methods. And among his inspirations was a caring, extremely collegial environment that I think is very unusual. Caring, collegial, highly collaborative, and that is a big part of the success, while at the same time extremely high standards of rigor, encouraging imagination, encouraging encouraging one to be iconoclastic, to challenge, to innovate. Spectacular role model. And I think the department, I guess he's been away from us for, I don't know, 15 or 20 years when he went to Oxford and passed away several years ago. The spirit that he created was so powerful that I think it still has a huge influence to what this department is. And while a relatively small department, why we have been really so enormously influential worldwide. Small department, relatively small department. If you go to some of the big US schools, Clinepi schools, relatively small, in a small university, and yet so influential. And it's all those things that Dave Sackett established, that he created an ethos that is continued. Those of us who were trained with Dave picked up that ethos. I'd like to think we've passed it on to subsequent generations. So amazing guy, amazing contribution.
Now take me through your residency was in which particular area?
Internal medicine.
Okay. And so as a medical student, how were you drawn into internal medicine? Is it something that you knew right away? Did you, like kind of the process of, trying to figure things out, or
yeah,
was it something?
So I think my impression at the time was that it was, one way to put it, it was the most intellectual area within medicine. It was so it contrasts to surgeons, where one of the jokes about surgeons is a surgeon is running for an elevator that's about to close. What part of himself does he stick in to keep the door from closing? The answer is the part he uses least often, his head. And so that's how internists think about surgeons.
Right.
But so we think we're the intellectual types in the whole medical field, and I think that's what attracted me.
Now, was there, I look back at my training as an ophthalmologist, and I specifically remember there was two cases that I had that really influenced my decision to go to do a master's in clinepi. And so I had, within a period of a couple of weeks, I had two patients with an ocular stroke. One was a very young person who ended up having a bicuspid aortic valve, which subsequently was quickly replaced, and then an elder person who had severe carotid artery stenosis. And at that time, there wasn't really great evidence to understand, like, how should we look at the systemic, or evaluate their systemic side of things. And so that was like, okay, this is a great research question. And then I went and kind of built a research program around that. So I'm interested, in the very early days, you're doing your internal medicine, or maybe you started your research career before your residency.
No.
During residency, okay.
No. So, as a matter of fact, I was pushed and dragged into it.
Okay.
So I knew I wanted to be in an academic environment, but I love teaching, still love teaching. Love teaching. I want to be a clinical teacher. And then my chair of medicine said, Gordon, 15 years from now, you will be bored. It may seem great now, but you're going to be bored. You really should think about research. And then I had another mentor who was Bill Goldberg, who was a real clinician, swinging stethoscope, chief of medicine at St. Joe's. I said, Bill, what do you think? He said, Jack may be right. You should give this a try. So I went in, I then, all right, okay, I'll give it a try. I then started the master's in clinepi, and I thought, hey, this is interesting stuff. And then a little while later, hey, it seems I'm kind of good at this. And then I got hooked.
Interesting. And is there a way to create a process? So let's say there's a medical student out there who's interested in maybe a career in research or interested in pursuing an academic career. Is there a way that we should be suggesting for them to start, or maybe it's a resident, to start their research career? What do you recommend?
Yes. So think about, are you more interested in the applied or more interested in the basic? And then ask around and maybe do a little finding out about people, and go and see the most interesting, exciting person you can think of on your faculty and say, hey, you're looking for residents to help out. And that's the general theme that it is much more likely that the fire will be lit by working with someone who's interesting and exciting to work with, and one's ultimate career is to a huge extent determined by mentorship. So find the right person.
Right. And so we were talking earlier about David, and so did you seek out Dr. Sackett, or how did that sort of play out?
Well, I think I was. I think it became obvious pretty quickly that I was talented in this particular area, and I was seen as somebody who, by the leadership in the department, as somebody who would benefit from the right mentorship and was being groomed for potentially over the long term a leadership within the clinepi clinical research endeavor. And so I think I was directed to Dave on that basis.
Got it.
So I
Now,
was fortunate. They said, "Okay, you should have the best," and they sent me to the best.
that's pretty amazing for sure. We were talking just before we went live here that when I did my master's in epidemiology, like your book was really kind of one of the seminal tomes for us. And so just walk me through the creation of the book Clinical Epidemiology. How did that start? What was it? What was it actually like to do that?
Well, the clinical epidemiology text was started by Dave and Peter Tugwell and Brian Haynes. And so they put out the first edition, and maybe they put out the second. I don't remember when they got me involved. Maybe it was the second, but they asked me to join them to put together what they called clinical epidemiology, a basic science for medicine. So they saw they saw clinepi as the basic science for clinicians. And so I just came. So they started that particular text, and then I got involved, and then that morphed into Dave had his EBM text, and we created the user's guide to the medical literature.
And so that was the series around through JAMA,
Yeah,
the user's guide. Yeah.
so Dave had an enormously successful series that he led along with Brian Haynes and Peter Tugwell, published in the CMAJ, which was the reader's guide to the medical literature. And the critical appraisal, Dave used the label critical appraisal, it was started as a classroom activity. And I think it became evident that that's probably not going to have too much impact. And so Dave had the idea of bringing critical appraisal to the bedside. And bringing critical appraisal to the bedside eventually morphed into evidence-based medicine. And it was about a decade out from the publication of Dave's series. We said, there are a number of limitations to that series, and it is not sufficiently oriented to what clinicians really need to know, which is understanding the results and applying them to their patients. And so we said we need to restructure this in a way that is that gets at what clinicians need to know. And this has become more and more evident over the years. Clinicians need to know less about how to critically appraise and risk of bias and that stuff. What they really need to do is to be able to understand the results, have someone tell them what the quality of the evidence is, and understand how those results apply to their patients. So we then started, so the reader's guides that were published in the CMAJ morphed into the user's guides to the medical literature, which was published in JAMA. And again, Dave, in his generosity, encouraged me to take the lead on that particular series, which I did. And those users' guides then published over 30 articles in JAMA, and that became the book, The User's Guide to the Medical Literature.
And I mean, you just look at the impact that series has had, on multiple generations of physicians across the world. When you were writing it, did you ever conceive that it was going to have that sort of impact?
Probably not. We were ambitious about it. We knew even those readers' guides in CMAJ, Canadian Medical Association Journal, had a big impact. So we probably had, and they're published in JAMA, world's biggest circulation journal. So we had an idea that it could be important. And we were that got started. That actually started just before we came up with the evidence-based medicine label. And so so we thought those users' guides would have an impact. What has been overwhelming, and obviously the users' guides are a core element of this, but what's been really overwhelming is the impact of evidence-based medicine and that whole way of thinking that's had in medicine. That, I think, outstripped our wildest dreams and expectations.
And who was the? I mean, was it yourself or was it David or who came up with the term evidence-based medicine?
I came up with the term evidence-based medicine, and
Amazing.
the story is this. In 1990, I took over the residency program in internal medicine, and at that time, we knew. I wanted to say, we thought we had a new way of teaching medicine. That it was really, I had found out when the way I was trained as a medical student in the first years of my residency, and what eventually I found this was really a new way of thinking when I was on and earlier in this conversation, and it is a different way of thinking that, as I said, transfers, once you're thinking that way, it transfers to life in general. So you asked me, okay, does being in the arts make you a compassionate physician? And I immediately think, I have no idea. I would need evidence to be able to answer that question, and intuition just does not cut it. So it's a way of thinking. So that way of thinking, and everybody was, but still to some extent, everybody at that stage was physiologic reasoning for this, that, and the other thing, where it's in many instances, sometimes it works, but just as often, but very often it doesn't, and we don't know until you have evidence about it. So it really was a different way of thinking, and required learning about the medical literature. I remember as a beginning resident, a staff person actually gave me this advice about reading the medical literature. You're not going to understand the methods and results. Don't bother trying. Read the introduction and discussion. Okay, and so this was so that's what it wasn't people weren't taught to use the literature properly, so we were going to do something, so we were going to teach this different approach. So I said, okay, I want to bring people to McMaster who'd be interested in learning. This is going to be different from other places. We want people who are open to it. So come to McMaster to do what exactly? Needed a name. Well, my first notion of the name was scientific medicine, because this was based on science. Anyway, I was introduced by the then chair of medicine to the internal medicine department as the new head of the residency program. And I had sent out a document beforehand. This is actually what got me the job, because I had another senior guy who was competing against me, who was a good senior guy, but they gave me the job because I put together this 10-page summary of what I wanted to do with the residency program.
Wow.
And people found that compelling. So when I got the job, I said, let's send it out to the department. And the response among the basic scientists who dominated the department, the academic department, was rage. And I was introduced to the department. The first question the guy asked me, he was so angry, he was shaking. We're the scientists. What do you mean calling this scientific medicine? We're the scientists, not you, second rate. And because then, the clinical research world was certainly perceived by the basic scientists as second rate. This
Sure.
isn't real science.
Sure.
So, and you're calling this scientific medicine? How dare you? And this was, I was told that the 2 or 3 times, John Cairns, the chair, who was ready to stand to say, okay, Gordon, the rotten tomatoes will be coming soon. Sit down, you've had enough. But each time I managed to respond so that he let me finish. But at the end of that, I thought, this scientific medicine probably isn't such a great label for this. I thought, well, now what will I call it if I don't call it scientific medicine? And my second thought was, okay, let's call it evidence-based medicine, which turned out to be an extraordinarily catchy choice.
That's interesting. It's almost like something out of Mad Men, with the ad agency and looking at MRI data. So it's that's interesting. So actually, we've got a great question here that's coming in from Justine from McGill University, and they're asking: as the 14th most cited scientist in the world. What advice do you have to students who want to pursue a career in research?
Okay, so I'm repeating what I suggested previously. The number one is mentorship and your research environment. That is, I would say, by far the most crucial thing. You pick the right mentor, and you get somebody hopefully who is inspiring, who teaches you the habits of research, who emphasizes that it always needs to be top quality, who hopefully, I would believe, emphasizes the need for collaboration, who is generous and supportive, and productive. Those are the things. Getting the right mentor is overwhelmingly. You get the right mentor, any talent you have will be brought out. You will develop the right habits as a researcher. You will learn about interacting with people in the academic environment in a positive way. You get the wrong mentor, pretty tough to even get started. So mentorship definitely is number one.
Yeah, and I'm going to pick up on that a couple of key things that you mentioned. I think it has to be a two-way street. So the mentor has to be willing, to give you advice. And I think, you talk about habits, and I think you also earlier on in the conversation talked about your father as being, someone who was very, disciplined and focused in his approach. And I think like that's the other key too. You can have a phenomenal mentor, but if you're not following through on the recommendations that they're making, and if you're not doing the hard work, then the results aren't going to be there as well.
Okay, so yeah, so great point. So pick the mentor, but it's at least as much hard work as it is smarts. So commitment and readiness to work hard, like I guess in a lot of things in life. So if you want to be successful in research, pick the right mentor and be ready to work hard. Because another thing that, having done over 30 years of mentorship myself now, the students who work hard are the ones you're ready to. I mean, I think I certainly try to do my best for all my students, but they're the ones who you're ready to give that extra for, because they're ready to make the effort themselves.
Now having gone through, this over the past, 30, 40 years, you must have had a phenomenal ability to manage your time. And the other side of that is, how do you're living your life, and, work's obviously a prominent part of your life. What do you do, or any tips that we can give our students for life-work balance and how to manage their time?
Find the right spouse who's ready to let you work really hard, and who isn't. Perhaps no academic doesn't have those tensions, but you certainly seriously. The success in the academic life involves a deep commitment to your work, and you need a family environment that's going to accommodate that. And yes, the phrase of "work hard, play hard" is a good one. Hopefully, again, if you're a low energy person, academic research may not be the right place for you. So if I look around at the most successful people around me, the whole bunch of us are all hypomanic. It requires and if you have the energy, then you can work really hard. And then when you turn to your family, and as a lot of people say, it's and I'd like to believe the quantity is, there's a certain minimum quantity, but after you've met that minimum, it's more the quality than the quantity of your interactions with the family. And if you're worn out, and the other thing I think you need, it's only right. The other thing that helps a lot is when you love the work, because when you love the work, when you turn to be your family, you've actually been, even though you've worked hard, you may be somewhat tired, you've actually been energized to some extent by the experience in the work and ready to have that energy for your family. So right family, ready to make some accommodation, but then to be ready to whatever you do, make sure that you have the energy and positive spirit to really be the time you do spend with your family, to make that as positive and as exciting, interesting, and lively with them as possible.
Interesting. Now, I've got another student who's written in here, Matt, who's interested in your decision to run as a political candidate. So walk us through, behind the scenes, what was going through your mind and why you chose that route.
Well, I co-founded a group called the Medical Reform Group, which the core thing that it was about was universal public health care, fostering universal public high quality health care, and um, resisting the inroads toward two-tier medicine, and indeed wanting to, as much as possible, expand high quality universal health care. So as that activity, we tried to get attention to, in every healthcare issue that came up, we tried to have some input around our basic approaches and philosophy. And I would write 20 press releases a year to try and get this out, and maybe 2 or 3 would get picked up and get some attention. So there was a lot of effort to a high ratio of effort to attention. But I got enough attention that I had a profile in my local community, and obviously the universal healthcare stance labeled me as a progressive. And the local NDP riding committee came over to my house and said, "We'd like you to be our candidate." Oh, this is kind of flat. Run federally, so you have zero chance of winning, as I did in my riding, which was a very good thing because I wanted to continue my career. But I thought this could be fun and interesting, and it was fun and interesting, and and the Canadian system suited it well. 30 days, basically 30 days, most of this is 30, 35, not much more than 30 days of a campaign. So you can start, and for 30 days you can be into it. You can put other things aside for 30 days, but you
Sure.
just have to put them aside for 30 days. And you have a voice. For 30 days, I had a voice. I loved the debates. The public debates were very exciting. I enjoyed going door to door. I would occasionally write something that would get some attention because I was a candidate. So for 30 days, I really had a voice that people would be listening. So, and that was enough fun that I did it 4 times, and in each case, no risk of winning, thank goodness, but it was still well worth it to have a public voice for 30 days.
That's very interesting. We've got someone, Simon, who's just written in, and he wants to know what it felt like and what your experience was like being inducted into the Medical Hall of Fame.
Well, it was fun. The so you know one does it, or hopefully one does all this because you want to make a contribution and you love the science and it's fun, but it doesn't hurt to get some recognition. And so the so and it was a great it was a great they put on an excellent show. So it was my induction happened to be in Hamilton, and I don't know, they got it in this big banquet hall, several hundred people, and they had a neat thing that you got to pick your music. So you pick some music beforehand. I picked Eine kleine Nacht music, the beginning of Eine kleine Nacht music, Mozart, anyway, they brought you up and you got to give a 3-minute little talk, which I had a particular message that I want to give, and that was great. And of course, you get to, I think they gave you a table with a dozen people that you could bring your family and
Oh,
those close
wonderful.
to you. So it was a lovely, it was a lovely celebration, and of course, very nice to. One hopes one is making an impact, and that's I'd like to interpret it that that's the world telling you you've made an impact and you've done something important that people value. So that's very nice.
And looking back on it, again, let's put the lens on the research career for a sec. What do you most, in terms of the one paper or one research idea that you're most proud of? What would it be?
uh, I'm fortunate that there are 3 or 4 in somewhat different areas. But if I were picking, I guess I would have to say the first paper in the user's guides, which introduced the user's guide. So why is it the one? So it's not just that paper, it's the user's guide as a body. But if I were picking one paper that symbolized the whole user's guides, it would be the introduction to the user's guides.
And having had such an illustrious and long medical career, if you're looking out for over the next 20, 30 years, where do you see the medical profession is going, and do you see maybe some threats out there that are going to change the way of life for physicians?
Well, if physicians, so there's clearly the physicians, it tends to be a somewhat conservative profession. The doctors, when Tommy Douglas first brought in Medicare in Saskatchewan, the physicians had a strike. When the Ontario government brought in the legislation that made it illegal to bill patients for insured services, the doctors had another 30-day strike at that point. Doctors tend to lose these strikes when they are, as far as I can tell, striking for self-interest over the public interest. If you just talk to any of our colleagues in the United States, you will see how good we have it. Universally publicly funded healthcare is good not only for the patients, but it's good for the physicians. And doing things that undermine public health care for a few extra bucks is very bad judgment on the part of the profession. So any move away, and now I feel like for the last 20 or 30 years, I've been defending the public system against inroads. We now have the potential of universal pharmacare. Government finally seems interested in that we can actually extend it, and that would be positive. So that's one thing. And the general, if we don't take care of discipline ourselves and do things that are in the public interest, that's when things are going to be imposed on us. And for the time being, if you just go south of the border and see how the medical life it's awful. So there is this huge focus on documentation. I have to spend very little time on documentation. They have to spend hours and hours and hours in documentation. They have to spend hours and hours focused on the billing. They have staff that they have to pay for. They've got big insurance that they have to pay against medical insurance, about 4 times or more that we do. I think in part that's because in the Canadian system, people realize the medical system is there for them and not for doctors' incomes or for the system. So all those things are a potential threat, which can be avoided if we as a profession stay committed to universal high quality healthcare for all Canadians.
Yeah, it's true. I did part of my training in both Philadelphia and Boston, so I saw that at firsthand. The degree to which there's documentation that's necessary to do things.
And it's got, I'm sure that's a while ago, it has
Yes.
gotten much, it's gotten much worse. It's gotten much worse since then. And then there is the other issue, having to worry about whether your patients can pay or not and what their insurance is, which is, I mean, I think it's immoral, but it's certainly not very pleasant.
So, one last question for you, and again, it's a bit of a retrospective review in the sense that you've accumulated this incredible fund of knowledge, but when everything is kind of said and done now, and you look back on your career, and now you have a chance to talk to a 20-year-old or 25-year-old, what advice do you give them, or maybe it's advice to your 25-year-old self?
Well, so unfortunately, I'm going to have to ask for clarification. Who is this 20 to 25-year-old I'm talking to? It's a young medical student and who wants to career in research, or who just wants to be a good doctor, or what?
Why don't we say it's advice to your 25-year-old self?
Advice to my 25-year-old self would be, take advantage of your opportunities. Look around you and say, who can help you? Where is, take advantage of your opportunities in the context of what excites you. And so I'll tell another story of that. So I already had my progressive politics, and I thought, where can I be? Where can I bring these politics into my medical practice? And I started as a chest physician because I thought chest physician, and particularly occupational medicine, would be a great way to, bring the politics of advocating for people, because of course all the problems in occupational lung disease. And I went to my first international meeting, American Thoracic Society, and I attended all the occupational respirology, occupational lung disease sessions. And they were boring, boring, boring. I thought, I don't care, this may be politically the right thing to do, but that's not for me. And everything I've done subsequently, I would have said to myself at that point, do what interests you, do what you love. Other considerations, financial or practical, what excites you and what makes you feel good and what makes you feel alive and what interests you, that should be your criterion for what you do and what you pursue.
That's wonderful advice. Dr. Guyatt, it's been an absolute pleasure to be able to learn about your career. Thanks so much for all the wonderful advice to our medical students.
Thanks very much. It's been a pleasure from my end.
Thank you. And for each of you who have taken the time out of your day to listen, we really appreciate it. We're going to be working on a number of great shows, potentially Dr. Robin Cook, who's I think sold 400 million books, who's a serial bestseller, New York Times bestseller author. We have James Clear coming up, who's really one of the experts in building habits. If you like what we're doing, feel free to subscribe and like our shows. Thanks for tuning in.